Yeah, there are many tumors that arise in the stomach. We are not going to consider all, but we are going to consider the ones that you will commonly encounter in your clinical practice. So out of all the tumors that arise in the stomach, the most important ones are the carcinomas. Now, from your neoplasm lecture series during the foundation module, you know that a carcinoma is a epithelial malignant tumor arising from the epithelium, which could be either squamous, glandular, or urothelium. So here in the stomach, the commonest epithelial malignant tumor that you get is the adenocarcinoma, because of course the stomach is lined by the glandular epithelium. However, less commonly you can get squamous carcinomas, a combination of adeno and squamous carcinomas, and tumors that are so undifferentiated you cannot say whether they are squamous or glandular, and another tumor known as gastroblastoma. But I'm not going to do all, I'm only going to do adenocarcinoma, which is the commonest cancer in the stomach. Then, of course, I will talk a bit about neuroendocrine neoplasms, because you may encounter patients having neuroendocrine neoplasms in the stomach as well as in other parts of the gastrointestinal tract. So those neuroendocrine neoplasms are classified as neuroendocrine tumors as well as neuroendocrine carcinomas. So we'll see what the difference is. Then I will talk a bit about benign epithelial tumors. Now you will wonder why I'm talking about benign ones after the malignant ones, because in clinical practice, you will see more malignant tumors than benign epithelial tumors. Then also you have tumors that arise from mesenchymal tissue, and there are many. Starting from gastrointestinal stromal tumor and other benign and malignant tumors that arise from adipose tissue like lipoma, liposarcoma, myofibroblastic tissue, inflammatory myofibroblastic tumor, smooth muscle tumors like leiomyoma, leiomyosarcomas, then vascular and other perivascular as well as neural tumors like schwannomas. So, but the ones I have mentioned in black are not so common. So I'm only going to deal with gastrointestinal stromal tumor, which you may see as you start practicing medicine. Then, of course, tumors or malignancies that arise from lymphoid tissue, though they are called lymphomas. So we, in that category also, I will only talk about Malt lymphoma, which stands for mucosa-associated lymphoid tissue lymphoma. It's also known as extranodal marginal zone lymphoma. So of all the tumors that you can get in the stomach, I will be considering only the common ones. And I will start with the most important one, which is the adenocarcinoma. Usually when you hear the word carcinoma stomach, that is what it means, adenocarcinoma of the stomach. So now these are some other synonymous words. Some people call carcinoma stomach gastric carcinoma. Then in layman's term, some may call it gastric cancer, some may call it stomach cancer. So, but all these names imply that it's a malignant epithelial tumor rising in the stomach. So I will be using some of these terms as I go on, but it means the same thing. So if you look at the estimated age standardized mortality rates for gastric cancer few years back, this is from the World Health Organization, you can see that, different areas of the world have had different mortality rates for gastric cancer. It has been highest in this area, Japan and Eastern Europe, and some parts of South America as well, but not so in North America, Australia, and some parts of Africa, etc. Can you see the screen changing?
No, madam, it's not changing again.
What's happening? Saying screen sharing is paused. Why is that new share? Only. Can you see now?
Yes, madam. Now we can.
Okay. So this is the age standardized mortality rates in different parts of the world. So you can see that the highest mortality rates are in this area, Japan, Eastern Europe, and in some parts of South America as well. Whereas North America, Australia, and some parts of Africa are less affected by this malignant tumor. So if we take Sri Lanka, now, you know, this data is a bit old. It's only up to 2012, but still you can see a steady rise in the incidence of gastric carcinoma. So I'm sure by 2022, 10 years later, it could be even higher, but we don't have the exact data for gastric carcinoma, because some of these people are treated in the private sector, some are treated by Ayurvedic physicians, and not all are reported to the cancer registry. So gastric carcinoma or adenocarcinoma can occur either at the cardia, then it is called cardiac cancer, which is mostly similar to cancers arising, adenocarcinomas arising at the gastroesophageal junction. So they have similar etiological factors and also prognosis and behavior. But non-cardiac cancer, which is commoner, usually arises around the pylorus and the antrum. So even risk factors for gastric carcinoma, we consider as cardiac for cardiac gastric cancer and for non-cardiac gastric cancer. So I said cardiac gastric cancer is similar to those adenocarcinomas arising at the gastroesophageal junction, and the commonest risk factor is gastroesophageal reflux disease. So with gastroesophageal reflux disease, you have replacement of the squamous mucosa of the esophagus by glandular mucosa, and in the cardiac region, which is called Barrett's metaplasia, that replacement, and it can also undergo dysplasia and give rise to malignancy. And why is obesity a risk factor? It is because patients who are obese have the esophageal sphincter tone at the low end of the esophagus is less in obese patients, so that there is more reflux of acid into the esophagus with, you know, Barrett metaplasia, and also development of dysplasia and cardiac type gastric cancer in those people. Whereas in non-cardiac gastric cancer, which occurs much more commonly in the pylorus and in the antral region, there are three important factors. You have environmental factors, host factors, and genetic factors, and all three play a part. So out of the environmental factors, the most important is this infection by this bacterium known as H. pylori, Helicobacter pylori, shortened as H. pylori. So this was the first bacterium that was identified as a carcinogen. So infection by H. pylori may predispose to gastric carcinoma. We will see how as we go on. Then dietary factors, of course, have become less important because in olden days, when refrigeration facilities were not available, people used to preserve food in jars. And when you preserve food, there are these carcinogenic agents that are formed, nitrites and nitrates. And they also used to smoke and salt fish and meat. So that also creates some carcinogens that can give rise to gastric carcinoma. And in also, like if you're in an area which lacks fresh fruits and vegetables, that is also supposed to predispose to gastric adenocarcinoma. But now, with refrigeration being widely available, these food preservative habits have, lessened, and smoked fish and meat, salted fish and meat, and nitrites and nitrates that is present in preserved food, people consume less. Now, it's interesting where people living in the Mediterranean region in the world, they're supposed to eat more fresh fruit and vegetables, and that is supposed to be protective. And the low socioeconomic status is a risk factor, probably associated with H. pylori infection and cigarette smoking as well. As you know, cigarette smoking predisposes to many malignancies. Most importantly, the lung carcinoma, which you all have already learned by now, but even for gastric adenocarcinoma. So what are the host factors? Sometimes, especially with the H. pylori infection, there can be chronic inflammation of the gastric mucosa known as gastritis, chronic gastritis, that could lead to intestinal metaplasia, metaplasia of the gastric epithelium with intestinal epithelium containing goblet cells. So those are predisposing factors to development of gastric adenocarcinoma. Metaplasia itself is not, but metaplasia could be associated with dysplasia. And sometimes patients with peptic ulcers, benign ulcers of the stomach, may undergo partial gastrectomy. And with partial gastrectomies, you can have more bile acid reflux and altered hypochlorhydria due to reduced acid. And all those may give rise to some sort of altered environment in the stomach with which predispose to gastric adenocarcinoma. And also gastric adenomas, which we are going to look at in detail as we go on. These are benign epithelial tumors. Genetic factors, especially genetic factors, genetic changes you can get in sporadic cases as well. Sporadic means gastric carcinomas just occurring out of the blue in one family. But sometimes you can have hereditary gastric cancers where more than one person in a family is affected. So, as you know, TP53 is a tumor suppressor gene. So, when TP53 is mutated, you can develop gastric adenocarcinoma, and you may see it in sporadic cases. Now, you can see it in both types of gastric adenocarcinomas, which we are going to talk about as we go on. But right now, there are two types, intestinal and diffuse types. I will explain it further as we go on. Then, patients with abnormalities or mutations in the APC gene, adenomatous polyposis coli gene, you get it in familial adenomatous polyposis, where patients have hundreds or thousands of small polyps in the intestines, but they can also have polyps in the stomach. And they develop intestinal type of gastric adenocarcinoma. Then there's another genetic change, germline mutations of this CDH1 gene, which is a tumor suppressor gene, encoding for E-cadherin. And E-cadherin is a protein that promotes cell adhesion. So when E-cadherin is not produced due to mutations of this gene, there is loss of cell adhesion. So you will develop diffuse type of gastric adenocarcinoma. And then BRCA2 gene, which is important for breast carcinoma, can also be mutated in gastric adenocarcinoma. So all in all, you have environmental risk factors, host risk factors, and genetic factors for gastric adenocarcinoma. So H. pylori, I mentioned, is a very important bacteria that when it colonizes the stomach, it can give rise to different pathological changes, a spectrum which may progress. Initially, it may give rise to a chronic gastritis. Usually, this bacterium colonizes the antral region of the stomach. So you have chronic gastritis of the antrum with severe gastric atrophy leading to intestinal metaplasia and dysplasia and cancer, as I told you before. So for this process to occur, this H. pylori bacterium has virulence factors, and an important virulence factor is known as CAG-A. So this is to show you a gastric mucosal crypt, and these are the H. pylori organisms. So you can see that they are on the surface of the luminal epithelium. They have not invaded the epithelial cell. So how do they give rise to their pathogenesis? I will very briefly show you using these pictures. Gastric epithelial cells have a mucus layer protecting the epithelial cells from digestion by gastric acid. But when the H. pylori organisms infect the stomach, they lie on the surface of the gastric epithelial mucus layer, and they start producing urease. So this urease will, by breaking down urea, will produce ammonia, which will neutralize the gastric acid. And it will also erode the mucus layer, so that more and more H. pylori organisms can come and colonize that area, as we saw in the picture before. And then with that, pepsin and hydrogen ions can cause damage to the epithelial cells. So the epithelial cells are damaged not by the organisms invading into the epithelial cells, but indirectly because they disrupt this protective mucus barrier. So with that, you have inflammation setting in, both active and chronic inflammation, and there will be mucosal cell damage and mucosal cell death. And with inflammation, there will be various growth factors that are secreted, which will promote the epithelial cell proliferation. So wherever there is epithelial cell proliferation, you know that there is a risk of developing neoplasia. So as I mentioned, its pathogenesis is multifactorial, with inflammation leading to cell proliferation. CAG-A virulent factor may stimulate growth factor pathways in addition, and the ammonia that is produced due to urease that is produced by the H. pylori also can promote cell replication. Additionally, they produce these nitrogen intermediates which can act as gastric carcinogens, and the inflammation will promote anaerobic growth, because inflammation, chronic active gastritis, will reduce the gastric acid production, promoting anaerobic growth. And this anaerobic growth will further promote formation of carcinogenic nitrous amines. So the pathogenesis of Helicobacter pylori infection is multifactorial. So lot of carcinogens are produced and cell proliferation is promoted. So it's a bad combination. So coming back to gastric adenocarcinoma, now I'm talking about non-cardiac cancers. Cardia is involved only 25%. If you look at the other non-cardiac cancers, the commonest site affected is the pylorus and the antrum, which is about 50%, and then the lesser curvature. So commonly you have tumors arising here, then you can have some tumors arising in the lesser curvature as well. So I said that there are two types of gastric adenocarcinoma, which appear to have some different pathogenetic basis. Intestinal type is what you see in high-risk areas like in Japan and Chile, etc. Older males are more affected, and it is associated with H. pylori infection, chronic gastritis, intestinal metaplasia, and also it may develop from precursor lesions such as gastric adenomas that I mentioned before. Whereas the diffuse type is usually associated with that gene mutation, CD8. Just a minute, Dean is calling me. I'll answer this. I'm at a lecture. Could I call you back? Yes. Okay, okay. Thank you very much. Thank you. Sorry about that. That was a call from the dean, so I had to answer. So diffuse type is associated with that CDH1 mutation with loss of E-cadherin and the cells losing their adherence to each other, and that is seen in at an earlier age, and it has no male predominance, and usually these tumors are more poorly differentiated. So now the most important thing of gastric adenocarcinoma is that, you know, the symptoms are similar to what you get with chronic gastritis as well as with peptic ulcer disease. So that is, you may have vague upper abdominal discomfort, vague dyspeptic symptoms, sometimes burning sensation, which are all features of chronic gastritis and peptic ulcer disease, and patients may disregard these things. Because of that, unless, you know, they undergo an endoscopic examination, most of them will start being treated for gastroesophageal reflux disease or peptic ulcer disease, and they may move on to a higher stage or advanced stage of disease. So unfortunately, this is what we see mostly in our countries. Most of our patients with gastric carcinomas present at an advanced stage with weight loss, anorexia. Early satiety means they can't eat much. They can just eat 1 or 2 mouthfuls and they feel full. They cannot eat much. Then anemia due to chronic blood loss, or hemorrhage due to severe erosion of the tumor into a blood vessel, or metastatic disease. So these are all features of advanced gastric carcinoma, whereas early symptoms overlap with chronic gastritis and peptic ulcer disease. So that is a tragedy, especially in our country, because we don't have a screening program. Of course, to have a screening program, the incidence of gastric carcinoma is also not that high in our country. So if we look at the clinical outcome, if you catch them at the early stage, when the tumor is confined only to the mucosa or the submucosa, even if lymph node metastases are there, they seem to do better. than patients with advanced gastric cancer, which extends deeper into the muscular wall. Deeper, it starts from the mucosa, goes into the submucosa, and when it goes into the muscle wall, it is at an advanced stage. So in countries like Japan, where the incidence of gastric carcinoma is very high, they have a screening endoscopy program for patients above, people above a certain age. So they usually catch their patients at an early stage. So Japanese endoscopists have developed these uh, classification for early gastric cancer, where it could be either protruded or just superficial or elevated, depressed or excavated. So early gastric cancer, they detect mostly where they have a screening program. Whereas advanced gastric carcinoma, where the tumor has gone beyond the submucosa into the muscle wall, again, has been classified based on the macroscopic appearance, but, it is not, it has no prognostic significance as far as I know, but the tumor could be either polypoid, fungating, ulcerated, or diffusely infiltrative. It is known as the Bowman classification. So these are all the macroscopic appearances of early and advanced gastric carcinoma. So just to show you some pictures. So this is a malignant gastric ulcer. So I suppose you all have done peptic ulcer disease and you all saw peptic ulcer, pictures of benign peptic ulcers. So if you can compare, you can see that this has irregular everted edges and the edge is very thickened. And if you look at the base has hemorrhagic areas and slough. So it does not have that beautiful punched out appearance which you get in benign peptic ulcers. So this is most likely to be a malignant gastric carcinoma. So similarly here, and this is of course a fungating tumor. So it can have different macroscopic appearances. Then those are now these fungating ones are mostly intestinal type of gastric adenocarcinomas that I mentioned before. Now, this is another pattern of growth where the mucosa is intact. You don't see a mass lesion or an ulcer. You don't see a protruding growth. But if you look, the wall of the stomach is greatly thickened. So we have a specimen in our museum. This is from our museum. You can see that the rugal folds of the stomach are nicely preserved, but you can see that the wall of the stomach is greatly thickened. Now, this is due to that diffuse type of gastric cancer where the cells are infiltrating singly because they have lost that E-cadherin cement which binds the cells together because of CDH1 gene mutation. So this type of appearance is called leather bottle stomach because in ancient times, some people, especially horsemen, they used to carry their water in a leather pouch like this. So it's called a leather bottle. And because this resembles a leather bottle, it's called leather bottle stomach or Linitis plastica. So if we are to diagnose a patient with gastric adenocarcinoma, we need material. So usually what we receive as pathologists is endoscopic biopsies from suspicious areas, and mostly it is not early gastric cancer. A lesion is visible. So either you get, if it's an ulcer, the biopsy has to be done from the ulcer edge, because if you do it from the base, you will only see necrotic material and slough. or if it's a polypoid growth or fungating growth, again, you have to take multiple biopsies. Now, in advanced gastric adenocarcinoma, patients may have metastatic disease as well. So this left cervical lymph node here, which is known as the workhouse node, is a classical metastatic site from gastric adenocarcinoma. So if a patient presents with a left cervical lymph node, we can do a fine needle aspiration cytology and identify malignant cells, and then tell the clinician to exclude the gastric adenocarcinoma. Then radiology is very important. This day and age, they could diagnose most of the things even without pathological confirmation, but still, before major surgery, always pathological confirmation is necessary. Radiology can show a thickened gastric wall in infiltrative type of gastric carcinoma. So these are the two histological types that I was talking about. Intestinal type, where you have gland formation. Still you can see gland formation, but of course, these are malignant glands because the cells are malignant. And that is the intestinal type as described by Lauren. Then this is the diffuse type, where the cells are infiltrating singly due to loss of E. cadherin due to CDH1 mutation. These cells have a mucin vacuole in the cytoplasm, and the nucleus is pushed to the edge, and it is supposed to resemble this type of ring, which is known as signet ring cell. So that is why some people call it signet ring cell carcinoma of the stomach as well. But it is actually the diffuse type. So these are the histological patterns. However, the WHO, now Lauren, I think, gave this specification so many decades ago, but still it's important. WHO likes to classify adenocarcinomas as whether it is tubular, papillary, mucinous, poorly cohesive diffuse type is the signet ring cell type, mixed pattern, micropapillary, etc. So this is another classification. So gastric adenocarcinomas can spread. Now you have done tumor spread. You know that malignant tumors can spread locally. They can spread by lymphatics. They can spread by bloodstream. And you have the peritoneal spread or dissemination as well. So local spread is usually into adjacent organs. Now, if this is the stomach, adjacent organs are the duodenum and pancreas or retroperitoneum. By lymphatics, it can spread to regional lymph nodes here along the lesser curvature, greater curvature, prepyloric nodes, etc. And it can spread via blood to the portal system, into the liver, and into the lungs as well. And this lymphatic spread is what causes that workhouse node that I showed you before, the left supraclavicular node. Then it can also, especially the diffuse type of gastric adenocarcinoma, can spread through the peritoneum. It can go through the muscle wall, through the serosa, into the peritoneum, and can cause peritoneal dissemination. And you have heard of Krukenberg tumors. Now this is a uterus removed from a patient with two large bilateral ovaries, right? So these are not primary ovarian tumors. This was found to be metastatic gastric adenocarcinomas of diffuse type. So they are called Krukenberg tumors. So as I mentioned, due to metastasis, you can have the supraclavicular sentinel lymph node known as workhouse node, periumbilical lymph nodes known as Sister Mary Joseph nodules, left axillary lymph node, Irish lymph node. Now, left axillary lymph node is an unusual site. and then ovarian metastasis known as Kuchenberg tumors, and it can spread through the peritoneum into the pouch of Douglas, causing the Bloomer shelf. Now, surgeons are very fond of these terms, so you better know, understand what they are, okay? So, what are the complications of gastric adenocarcinoma? It can have local effects and effects due to metastasis. So, based on the place where it is, you can have obstruction, especially in cardiac type of tumors, pyloric obstruction when the tumor is in the pylorus and antrum, and or it can have a large fungating mass in the stomach, giving rise to a filling deficiency leading to early satiety, which I explained to you before. Sometimes tumors, especially ulcerated tumors, can penetrate through the stomach wall and perforate, causing peritonitis. Bleeding is an important complication in any malignant tumor. When it erodes into a blood vessel, it can cause a massive hemorrhage and the patient can die of that also. But however, when the blood loss is small and more chronic, patients may have anemia. I mentioned that anemia is a feature of advanced gastric cancer. So without perforating, because the stomach is lying on the pancreas and on the duodenum, adjacent tumors can penetrate through the serosa of the stomach into either the duodenum or the pancreas. So that usually happens in stage 4 tumors, which I will explain to you later. So you can have effects due to spread of tumor when it spreads to lymph nodes, especially at portal hepatis, causing obstructive jaundice. It can cause liver metastasis, peritoneal deposits leading to ascites, and then sometimes gastric cancers can give rise to paraneoplastic syndrome. You know what paraneoplastic syndrome is. I will not explain it to you. If you have forgotten, go and check your book. Cancer cachexia is a feature of advanced malignancies and nutritional deficiencies, especially because stomach is the organ that receives the food that we eat. So, for prognosis, the most important is the tumor stage. You know what tumor stage is? You know the difference between tumor stage and tumor grade. We have done it for you all. Tumor stage is the degree to which the tumor has spread. Now, in this instance, it is the degree to which the tumor has spread through the stomach wall, mucosa, submucosa, or has it gone into the muscle wall, or has it penetrated the muscle wall and the serosa. So, when it has penetrated the muscle wall and the serosa is stage 4. When it goes into the muscle wall is stage 2. When it goes into the submucosa is stage T2. And when it's confined to the mucosa, it is stage 1. So stage is important. Patient with a stage 1 tumor will have a better prognosis than a patient with stage 4 tumor, obviously. Histological features are less important, but the diffuse type carries a much worse prognosis than the intestinal type. Then nowadays, some oncologists ask us to do this HER2 marker by immunohistochemistry because for tumors that express HER2, they have a targeted treatment, targeted molecular treatment. So sometimes they ask us to do the HER2 marker by immunohistochemistry. So HER2 is a predictive biomarker for gastric cancer as well as for breast cancer, which you will learn as you go on. So just few case scenarios before we move on, just for you to understand that patients with this type of symptoms may not always have gastric cancer. It could be other diseases as well. A 50-year-old man presents with dyspeptic symptoms and recent onset loss of weight. Examination reveals epigastric tenderness. So it could be gastric carcinoma, but at the same time, it could be gastroesophageal reflux disease, chronic gastritis, peptic ulcer disease. Another one, a 50-year-old chronic smoker presents with loss of weight and loss of appetite. On examination, he is emaciated, pale, and is found to have an enlarged left supraclavicular lymph node. So I mentioned that you can have supraclavicular lymph node in gastric carcinoma, but similarly, you can have it in lung carcinoma as well as in tuberculosis. So you need histological confirmation. Another one, a 35-year-old female presents with lower abdominal discomfort. Ultrasound examination showed bilateral enlargement of ovaries. It could be a primary ovarian tumor, as I mentioned before, or it could be metastatic gastric tumor. Similarly, another patient presents with jaundiced, liver is enlarged, a site is present. It could be some primary pathology in the liver, cirrhosis. It could be colorectal cancer with liver metastasis. It could be gastric cancer with liver metastasis. It could be carcinoma, pancreatic head, or ampulla. So you need to do appropriate investigations. So that concludes gastric adenocarcinoma, and I have to rush a bit because I have to complete the other ones as well. So these are the learning outcomes that I have covered about gastric adenocarcinoma. You can slowly go through it on your own. Before I move on, do you have any questions? Okay, let me move on. Then I will handle neuroendocrine neoplasms, which includes neuroendocrine tumors and neuroendocrine carcinomas. So neuroendocrine neoplasms are also gastric epithelial neoplasms, however, with neuroendocrine differentiation. What do you mean by neuroendocrine differentiation? Because these tumors express neuroendocrine markers like chromogranin and synaptophysin by immunohistochemistry. So there are different types of neuroendocrine neoplasms. When they are well differentiated, they are called neuroendocrine tumors. These are the ones that used to be called carcinoid those days. When they are more poorly differentiated, they are called neuroendocrine carcinomas. But both these will show positivity for neuroendocrine markers. Now you also have another category where neuroendocrine tumor can occur with an adenocarcinoma or a non-neuroendocrine tumor. Then that is called MNN, mixed neuroendocrine, non-neuroendocrine tumor. If you want, you can forget it. So neuroendocrine tumors, which used to be known as carcinoids, are usually related to autoimmune chronic atrophic gastritis. It can occur as part of multiple endocrine neoplasia type 1 associated with H. pylori infection as well. It can lead to usually a mucosal polypoid lesion, which will project out, but it could be intramural within the muscle wall, and usually it has a yellowish cut surface. Now, neuroendocrine tumors usually secrete various substances like histamine, serotonin, gastrin, somatostatin, or they could be non-active as well. And gastrin secreting neuroendocrine tumors will give rise to Zollinger-Ellison syndrome, hypersecretion of gastric acid. But usually now carcinoids in the small intestine can give rise to carcinoid syndrome, where you can have flushing and various other symptoms. You can look up what carcinoid syndrome is. But these neuroendocrine tumors in the stomach usually do not give rise to that carcinoid syndrome. So they have a characteristic architecture. It's called organoid architecture, where histologically it is very characteristic. There are nest cords and ribbons, and the cells are very, very uniform. You can see that the cells are very uniform, and they have a characteristic nucleus, which is described as a salt and pepper nucleus due to stipple chromatin. So these neuroendocrine tumors usually behave in a fairly good manner. However, they are graded based on the proliferative index or the mitotic count. So tumor grades 1 and 2 behave very well. Tumor grade 3 may be a bit more aggressive, but still they are much better than neuroendocrine carcinomas. And there is a special staging system for neuroendocrine tumors. It is not the same staging that you use for adenocarcinoma. Neuroendocrine carcinoma, on the other hand, will not show that organoid pattern that the carcinoids will have, and they are high grade by definition. So you don't usually grade neuroendocrine carcinomas. They are anyway high grade and they are more aggressive. They are subtyped as large cell neuroendocrine carcinoma as shown here. You can also have a small cell neuroendocrine carcinoma, which is similar to what you get in the lung. So that is neuroendocrine neoplasms, where you have neuroendocrine tumors, less aggressive, graded from grade 1 to 2, and neuroendocrine carcinomas, which don't have that characteristic organoid arrangement of cells. They are high grade and more aggressive. So moving on to adenomas, as you know, adenomas are benign epithelial tumors, and they can appear on endoscopy as small polyps, and they are biopsied. So we receive these small polyps and we look at the histology and give a diagnosis. So it could be small and single, or it could be multiple, especially in familial polyposis syndromes. So this is just a brief overview of polyps and adenomas that you can get in the stomach. From the surface epithelium, you have hyperplastic polyps, and hyperplastic polyps are again related to H. pylori infection and chronic inflammation, which can lead to overstimulation of epithelial cells to proliferate, giving rise to a hyperplastic epithelium. From the hyperplastic epithelium, you can also have adenomas, which are neoplasms, but they are still benign. You can have either intestinal type adenomas, like what you will get in the lower GI tract. You will have one full lecture on that, I think. So, or it could be foveolar type, resembling the gastric epithelium. So this surface epithelium derived polyps and adenomas can occur as syndromes, where you can have juvenile polyposis with multiple polyps, Peutz-Jeghers syndrome, Concrete Canada syndrome. You can look up these things if you haven't heard them before. Then you know that the stomach has specialized oxyntic cells. So you can have adenomas that arise from these oxyntic cells. Now surface epithelial cells are non-specialized. So here you have fundic gland polyps, oxyntic gland adenoma, pyloric gland adenoma, and fundic gland polyps are usually related to a proton pump inhibitor treatment. Now, you know, when patients who have gastritis are treated with proton pump inhibitors, and these things, long-term use can give rise to fundic gland polyps. And there can be some of these oxyntic gland-derived polyps and adenomas can also give rise to some syndromes, or they can occur in syndromes like in familial adenomatous polyposis. You can also have fundic gland polyps in addition to adenomatous polyps. And some of these things, especially intestinal type adenomas with dysplasias and some others, can act as precursor lesions for gastric adenocarcinoma, but not all. So that's a very brief overview of gastric polyps. Then moving on to mesenchymal tumors, there's again a long list, but I'm only going to introduce you to this gastrointestinal stromal tumor. In short, it's called GIST. So GIST is a mesenchymal neoplasm derived from interstitial cells of Cajal. These are cells that act as pacemaker cells of the GIT, promoting peristalsis. And they harbor tyrosine kinase receptor mutations, KIT, or platelet-derived growth factor-related mutations. And some of them may have other mutations related to the mitochondrial succinate dehydrogenase complex. So they arise from the mesenchymal tissue of the bowel, and this is a tumor that can occur right throughout the gastrointestinal tract, from esophagus to the rectum, but they are most common in the stomach. And they can either project into the lumen, then they can give rise to chronic bleeding with anemia, mucosal ulceration, acute bleeds, etc. Or it can go outwards towards the serosa, giving rise to perforation, or when it's large, an abdominal mass. So as you can see, this is a stomach that is removed, and this is a gastrointestinal stromal tumor. Histology will show spindle cells, unlike in the adenocarcinoma, and they are diagnosed by doing special immunohistochemical markers, just like for neuroendocrine tumors, we did chromogranin and synaptophysin. But for GIST, the two markers are CD117, which is KIT, and DOG1. So these tumors are positive. And that helps to differentiate these tumors from leiomyomas and leiomyosarcomas and schwannomas, which also have spindle cells arising in the stomach. So their prognosis, usually now mostly we know that we talk about tumor staging being the most important for prognosis, but for this, it is not the stage. Usually it's now if you take the whole of GI tract, where it occurs, usually GIST occurring in the esophagus and stomach behave in a much better manner than those arising in small bowel and large bowel. So addition to the site, the tumor size, mitotic count, and by molecule analysis, the mutation that you get, whether it is c-KIT mutation, PDGFRA mutation, or SDA mutated, so that will help to determine the prognosis. And also, especially when c-KIT is mutated, there's targeted treatment. So targeted molecular treatment, just like for gastric adenocarcinoma, we said we do HER2 because you have the patients can get targeted molecular treatment. So this is the last one, lymphoma. So these are malignant tumors arising from lymphoid tissue. Now, stomach is an organ that usually does not have any lymphoid tissue. But what happens is when the stomach, now there are different types of lymphomas. They are all non-Hodgkin's lymphomas. You will learn about non-Hodgkin's and Hodgkin's lymphomas when you do your hematolymphoid module. But these are in the stomach, you mostly get non-Hodgkin's lymphomas of B cell lineage, not T cell. T cell tumors are rare. And out of the B cell tumors, what you get is commonly Mold lymphoma, which I said is also known as extranodal marginal zone lymphoma. And most of these tumors, Mold lymphomas in the GI tract, occur in the stomach. You can also have diffuse large B-cell lymphoma and Burkitt lymphoma, but Mold lymphoma is the commonest, so I will talk about it. And it is also important because it is related to H. pylori infection. So I said that with H. pylori infection, you have chronic inflammation, and this chronic inflammation can lead to lymphoid follicle formation and then proliferation of abnormal lymphoid tissue leading to Mold lymphoma. And histologically, these are composed of small cells, and they go into the epithelium to cause lymphoepithelial lesions, which is characteristic of this type of lymphoma. However, clinical features and endoscopic appearance may overlap with H. pylori infection. So you have to do a biopsy to identify this. So sometimes when you eradicate H. pylori infection, some of these early stages of Mold lymphomas disappear. So it is curable by eradicating H. pylori. But later on, it becomes, when it moves into this diffuse large B-cell lymphoma category, it cannot be cured. So this is just a diagrammatic representation of a model how H. pylori causes Mold lymphoma. It causes chronic gastritis, which stimulates T cell proliferation. T cells will help to promote B cell proliferation, and these proliferating B cells will accumulate genetic alterations, mutations, and they will give rise to the Mold lymphoma. And now up to this stage, it is curable if you eradicate H. pylori, but later on it may accumulate additional genetic changes, and then when it moves to diffuse large B-cell lymphoma, it is not curable by H. pylori infection. So here we have now looked at adenocarcinoma, which is the most important. We looked at neuroendocrine neoplasms, neuroendocrine tumors, and neuroendocrine carcinomas. I told you how to differentiate. We looked at adenomas very briefly, gastrointestinal stromal tumors, and Mold lymphomas. So it's a very brief overview. I suggest that you go home and read your Robbins to get more information about these other non-gastric adenocarcinomas that I did, because it's difficult to do everything in a 1-hour lecture. So do you have any questions?